So doing a bariatric surgery for a donor before a donation sounds out of my book, actually, my syllabus. So let me talk about what I've been asked to talk about. So thin line between fertility and success. Why this topic? We understand that ACLF3, specifically ACLF3, is a condition where you are looking at almost 80 to 90% mortality at the end of 3 months if you don't do a transplant. On the other hand, we also need to understand that the survival after transplant also is not very great. So let's see if we can draw a line where we should be transplanting, where we should not be, how gray that line is, how wide that rectangle is where you can fit in these patients. So there are two separate definitions for ACLF. It is not my brief to talk about and say the pros and cons of each, but I am here to strike some similarities between two. Whether you talk about the apostle arc classification or you talk about Easel-Cliff, there are two things which are common in these two. So when you talk about ACLF3, according to ARC score, apostle classification, you have to have a score more than 11 to classify as ACLF3, which means you need to have more than 3 organ failures. So either 3 or 4 or 5 organ failures to classify that as ACLF3. Same thing is seen in Easel-Cliff. So one thing they agree about, what is ACLF3? If you have 3 or more organ failures, that is ACLF grade C. The second thing which they agree about is, when you talk about ACLF3 without a transplant, the 1 month and 3 month mortality is the tune of 80% according to the canonic study. And ARC's study tells us almost 92.8%. So that's the database they took. So you're dealing in a disease with a disease which has 90% mortality at the end of 3 months if you don't do a transplant. And this has been shown in multiple studies all over, less than 10% survival at the end of 3 to 6 months. What does liver transplant offer for ACLF3? The data started coming in 2015. This was the first talked about paper. There were a few case studies before this, but first talked about paper came from the Easel-Cliff Consortium. You will see that the ACLF3 patients are only 9, and they claimed 77% 1-year survival. The larger paper came in 2017. This was a Korean paper from Moon. 190 ACLF patients, of which a significant proportion were ACLF3. If you look at the survival of ACLF3 at 1 year and 5 years, it's 76 and 71%. Now, these are very carefully selected group of patients, which are giving you a 5-year 71% survival. And finally, I thought I'll quote this paper also. This is again from the European database. 73 patients with grade 3 ACLF transplanted, and the survival is 83% at the end of 1 year. All these papers tell you transplant does well for ACLF. Which patients should do, it does not tell you. It does not say about the predictors of mortality. This is an important paper. If you have not read this, you should go back and read about this paper. This is UNOS database taken from year 2004 to 2017. 8,267 ACLF3 patients who underwent a transplant. And the survival was 67% at the end of 5 years, which is actually not bad. If you look at a disease which has 90% 6 months mortality, a 5-year survival of 2/3 of the patients is not bad. What we need to answer is, can you improve this survival by a better patient selection? Is there a subgroup of patients who die more, who have a mortality more than 50% and hence should not be transplanted? Let's try and dig the literature if we have any data on that. So I have taken 3 papers here from 3 different parts of the world. The first one came from Europe, Easel-Cliff Consortium. This is 2021 paper. 308 ACLF patients from 20 centers across 8 European countries, and the time period was January 2018 to 2019. 98 patients underwent liver transplant for ACLF3, and 78.9% 1-year survival in these patients. That's not important. These are highly selected subgroup of patients. What is important is what they found out. Now, 3 factors, they said, predict mortality at the end of 1 year. One was pre-LT arterial lactate level, which I presume is an indicator of circulatory failure. Second is recent infection using multi-drug resistant organisms. And thirdly, any patient who required renal replacement therapy pre or during LT. So significant renal failure, a neuric patient who is requiring dialysis. So these are 3 factors which they talk about. They do not talk about ventilator dependence, Why ventilated patients? Because they did not transplant many ventilated patients. But this is shown in further 2 studies which I'm going to discuss. So this is again North American consortium. I've taken 3 separate studies from 3 separate parts of the world. 318 patients, time period is almost 1.5 years. 77 patients underwent transplant for ACLF3. At 1 year, 87% of patients, overall ACLF patients were alive. And ACLF3, 85% 1-year survival. Again, I'll tell you, survival is not important. Why? Because these are selected subgroup of patients. What is important is what predicts mortality. Here, important thing, pre-transplant respiratory failure showed to be predicting lower survival as compared to patients who did not have respiratory failure. They did not separately talk about intubated patients for long. They did not talk about any, but this study has its flaws, but this is one thing which they talk about. Secondly, any ACLF who has portal vein thrombosis has a significantly lower survival. We understand that more bloody surgery, sicker patient, more blood loss. But importantly, they did not show any difference in pre-liver transplant circulatory failure regarding survival versus, so patients who were on vasopressors at the time of transplant, when they were taken for transplant, and compared to those who were not on vasopressors, the survival was similar. Again, that does not tell us that vasopressor patients have good survival. We have to again classify this further. I'll talk about this subsequently in my last 2 slides. Third is from Delhi. My dear friend Shweta published this paper from Dr. Subhash Gupta's group. 4-year, 103 ACLFs underwent transplant. ACLF was defined as Cliff score. 54 of them had grade 3 ACLF. They showed a mortality which is what I would think is similar to what you see in real world. 26% at 1 year, 26% at 1 month, 39% at 1 year. But again, what was important was the predictors of survival. 1, respiratory failure, patients who were ventilated at the time of transplant. Secondly, post-operative renal replacement therapy. Now, post-operative renal replacement therapy is a very vague term. It's not important to me because by the time the patient is dying, you put the patient on dialysis. What is important to me is whether the patient was on renal replacement therapy before transplant, whether they were taken up for transplant or not. The paper is mute about that. So no matter how many papers you discuss, how much data you try to see very critically, you will only get data about patients who were transplanted. Nobody will give you data about patients of ACLF who were eligible for transplant but were not transplanted. What was the reason of refusing them? So what I did was, before I go back, before I end this presentation, I'll give you 2 slides of what I could gather from the literature and what has been our own experience. So what I've done is I have classified 4 organ failures and try to see what we do. So let's say the patient is on mechanical ventilation. Should it be a contraindication for transplant? You have to go back and see why the patient has been put on mechanical ventilation. If the patient has been put on ventilation because of grade 4 HE, does not have a lung injury, it's not a contraindication, obviously. On the other hand, if the patient has acute lung injury or ARDS, where the FiO2 SpO2 ratio is less than 200, SpO2 FiO2 ratio, that should be a contraindication because these patients tend to do worse after transplant. That has been my experience. I would like to hear from the experts also here. Secondly, renal failure. So somebody who comes with a high creatinine is classified as renal failure. You stabilize the patient, you give albumin, you give terlipressin, patient starts passing urine, creatinine starts decreasing. You transplant him at a creatinine of 3, he'll have a good survival. On the other hand, if you have a patient who has renal failure, he has a rising creatinine, his urine is going from oliguria to anuria. If you transplant that patient, he'll have a bad survival. So a worsening renal failure, need for RRT, should be a relative contraindication when you're transplanting ACLF3. You have to categorize your patient clinically, not go on the renal failure definition of creatinine more than 2. So anuria with rising creatinine, we will not transplant. Oliguria with stable improving creatinine, yes, we will transplant. Third, circulatory failure. So all the lactates which people talk about in the ARC score and in the studies which say lactate predicts post-transplant survival, lactate is an indication of circulatory failure. So if you have a high vasopressor requirement, which is actually going up, you should not transplant that patient. On the other hand, there's a patient who was on 3 vasopressors. You've been able to stabilize him. It comes down to 2 vasopressors. He's improving. His urine has started coming. You might transplant, you might get away with it. So you have to see what has been the temporal profile. It's not a decision of 1 day, 2 day. You have to see which way the patient is going and then take a call. Sometimes you may not get a window to get him off vasopressors. You might like to transplant him on a small dose. But on the other hand, a rising vasopressor should be a contraindication. And finally, sepsis. Lot has been talked about, lot has been said about sepsis. But in my opinion, if you have a culture positive, you give the appropriate antibiotic for 48 hours, and you document clinical stabilization of the patient, as in organ failures, patient is good for transplant. Thank you. I would finish here, and I would invite you and ask you to block your dates for next May for the DCLD, which we hold once in every 2 years. Thank you for patient listening.